If you've ever struggled with insomnia, there's a good chance you've had this experience. You can't sleep, you try melatonin, that doesn't work. Maybe somebody gives you Trazodone, that doesn't work, or maybe it leaves you exhausted the next morning. Then you try another medication, and another, and eventually you're saying, nothing works for my sleep. But here's a question I think we sometimes need to ask before we keep moving from one sleep medication to another. Why aren't you sleeping? Because insomnia is a symptom. And two people can both walk into my office and tell me I can't sleep, but they may have completely different reasons for not sleeping. One may be lying in bed with their mind racing from anxiety. Another may not become sleepy until 4 o'clock in the morning. Another may fall asleep easily, but keep waking up throughout the night. Another may be snoring, gasping, and experiencing untreated sleep apnea. And another may be sleeping 3 hours a night and telling me, but I'm not tired, I feel great. Those are not necessarily the same clinical problem, and they shouldn't automatically receive the same treatment. So today we're going to talk about what I call the sleep medication ladder, but more importantly, we're going to talk about what I want to know before we start climbing it. Hi, I'm Robin Trivett. I'm a board-certified psychiatric mental health nurse practitioner. I have a doctorate of nursing practice from Duke University. And on this channel, I use my years of experience in psychiatric nursing and mental health care to help you better understand mental health, psychiatric medications, treatment, and the questions that you should be asking about your care. And today we're going to be talking about insomnia and sleep medications. This is general education. It isn't individualized medical advice, and I'm certainly not suggesting that everyone with insomnia should or shouldn't take medication. What I want to show you is how much more there is to this conversation than simply choosing a sleeping pill. When a patient tells me they're not sleeping, I want to know what their sleep actually looks like. What time do you go to bed? How long does it take you to fall asleep? Once you fall asleep, do you stay asleep? What wakes you up? If you wake up, can you go back to sleep? What time do you wake up in the morning? Are you tired during the day? Are you taking naps? And most importantly, what is happening when you're awake? Are you lying there worrying? Are your thoughts racing? Are you physically restless? Are you having nightmares? Are you in pain? Are you simply not tired? Those details matter because before I decide that somebody needs another medication for sleep, I want to understand what kind of sleep problem we're actually trying to treat. And next, I want to look at the bigger psychiatric picture. Poor sleep can occur with depression, anxiety, PTSD, ADHD, related dysregulation, and importantly, mania or hypomania. If somebody tells me I'm only sleeping 3 hours, my next question isn't necessarily, what can I give you to make you sleep? I need more information. There's a big difference between I'm sleeping 3 hours and I'm absolutely exhausted, and I'm sleeping 3 hours, I have tons of energy, my thoughts are racing, I'm getting everything done, and I don't even feel like I need sleep. The second presentation should lead to a very different assessment. The same thing applies to anxiety. If somebody is lying awake for 3 hours every night because their mind is consumed with worry, adding a sedating medication may help them sleep. But have we adequately addressed the anxiety that's keeping them awake? Sometimes treating the underlying psychiatric condition improves the sleep. And if the psychiatric symptoms are improving but the insomnia isn't, that tells me something too. The point is that sleep doesn't exist separately from the rest of the clinical picture. This is something I really want people to understand. Not every sleep problem is psychiatric. I want to know about caffeine. How much are you drinking? And what time are you drinking it? Nicotine, alcohol, substance use. What medications are you taking and when are you taking them? Could the medication you're taking in the evening be activating? Are you taking a stimulant too late in the day? Are you taking something else that's interfering with sleep? And what about pain, thyroid problems, hormonal changes or menopause, restless legs, sleep apnea? If you're snoring loudly, waking up gasping, having witnessed pauses in breathing, waking with headaches, or you're exhausted despite apparently sleeping all night, I don't want to simply keep sedating you. We may need to investigate the quality of sleep that you're actually getting, because making somebody unconscious for several hours is not necessarily the same thing as treating the reason they're not sleeping well. Now let's talk about something that sometimes gets reduced to have good sleep hygiene. And I don't think that's enough. Cognitive behavioral therapy for insomnia, or called CBT-I, is a structured treatment for chronic insomnia. And it's much more than don't drink coffee at night, put your phone away, make your bedroom dark. Those things may be helpful, but CBT-I goes much further. It addresses the behaviors and thought patterns that can actually maintain insomnia. For example, if you spent months lying awake in bed, frustrated and anxious, your brain can start associating bed with, this is where I struggle to sleep. CBT-I works on changing those patterns. It may include strategies involving stimulus control, sleep scheduling, cognitive work around sleep, relaxation approaches, and other behavioral interventions. And one of the reasons CBT-I is so important is that the benefits can continue after the treatment itself has ended. So when we're talking about chronic insomnia, I don't want behavioral treatment treated like the unimportant thing we try before the real treatment. It is treatment. Here's another distinction I think is fascinating. Let's say somebody tells me I can't fall asleep. Okay, but then I learned they can't fall asleep until 4 o'clock in the morning, and once they fall asleep, they sleep very well until 10 or 11. Compare that with somebody who goes to bed at 11 o'clock, is genuinely tired, but lies there for 3 or 4 hours worrying. Both patients say I can't sleep, but those may be very different mechanisms. One may involve a circadian rhythm issue, essentially the timing of the body's sleep-wake system, and the other may involve anxiety or conditioned insomnia. Same complaint, different mechanism, different treatment. And that's one reason I don't want to choose a medication based solely on the sentence, I can't sleep. And then let's talk about melatonin, because almost everybody has heard of it. And a lot of people think melatonin is simply a natural sleeping pill. But I think it's more useful to think of melatonin as a signal that is involved in circadian timing. That means timing matters. And taking a huge amount right when you climb into bed isn't necessarily going to be any better. More doesn't automatically mean more effective. This is also where medications such as Melatonin come into the conversation. Melatonin works at melatonin receptors and can be considered particularly when sleep onset is the problem. Again, the question isn't simply, what's the strongest thing that will knock me out? We're trying to match the treatment to the problem. And now let's talk about a newer class of sleep medications that patients may not know much about. Dual orexin receptor antagonists. These include medications such as Belsomra or suvorexant, Dayvigo or Lumerexant, and Quviviq or Durexant. Here's an easy way to think about them. Orexin is involved in promoting wakefulness. So instead of thinking only about adding more sedation, these medications work by blocking orexin-mediated wake signaling. I think this is an important concept because it demonstrates that not every sleep medication works the same way. And just because a medication is approved for insomnia doesn't mean it's appropriate for every person. We still have to consider medical history, other medications, side effects, age, fall risk, next day functioning, and the particular sleep complaint we're treating. And then we have medications sometimes called the Z drugs. Examples include zolpidem or Ambien, eszopiclone or Lunesta, and zaleplon or Sonata. These medications can be effective for insomnia and still have a role in treatment, but they also require thoughtful prescribing. So we have to consider things such as next day impairment, duration of treatment, other sedating medications or substances, and the risk of complex sleep behaviors. Complex sleep behaviors can include doing things while not fully awake and potentially not remembering them afterwards. So this is another situation where it makes me sleep isn't the only question I care about. I also care about what is happening while you're taking it and how are you functioning the next day. And then there's Trazodone. We have to talk about Trazodone because if you've ever been treated for insomnia in mental health care, there's a pretty good chance you've at least heard about it. Trazodone is an antidepressant, but it's very commonly prescribed off-label for sleep. And there is some nuance here that I think gets lost online. The American Academy of Sleep Medicine's 2017 pharmacological guidelines suggested that clinicians not use Trazodone specifically for chronic insomnia. But I want to be careful about what that means. That recommendation was based on the available evidence and was a weak recommendation. It does not mean Trazodone is universally dangerous, and it doesn't mean no patient should ever receive Trazodone. I prescribe Trazodone, and my experience has been while Trazodone helps my patients go to sleep, it doesn't seem to help them stay asleep. What this means is we shouldn't take an older guideline and turn it to an oversimplistic medication ranking. And Trazodone isn't without potential side effects. It can cause morning sedation, dizziness, orthostatic hypotension, which means your blood pressure can drop when you stand. And there can be serotonergic considerations when it's combined with other medications. So once again, why are we using it? What else is the patient taking? What other conditions are we treating? And what happened when they took it? And is it actually helping? There's also medications I want to be thoughtful about before using routinely for chronic insomnia. One of these is diphenhydramine or Benadryl. Just because something is available over the counter doesn't mean it's the best long-term treatment for insomnia. Repeated antihistamine use has its own side effect consideration, and those concerns become particularly important in older adults. So I also don't want to automatically reach for benzodiazepine as a brand new long-term strategy for chronic insomnia. There are situations where benzodiazepines are prescribed, but we need to think about tolerance, dependence, cognitive effects, falls, interactions with other sedating substances, and what happens with continued use. Again, this medication is good and this medication is bad. Does the benefit make sense for this particular patient, for this particular problem, given the risk? So now let's go back to the patient who tells me, Robin, nothing's working for my sleep. Maybe they've tried melatonin, Trazodone, and an antihistamine, a Z drug, maybe several other things. And at this point, I don't necessarily think the next question should be, okay, what medication haven't we tried? I want to go backward. What kind of insomnia are we actually treating? Is the problem falling asleep, staying asleep, waking too early, a circadian rhythm problem, anxiety, depression, PTSD, possibly mania or hypomania, pain, restless legs, sleep apnea, medication side effect, substance use, hormonal changes, or have we developed behavioral patterns around sleep that need something like CBT-I? Because sometimes repeatedly changing the medication without revisiting the diagnosis and the mechanism means we're treating the symptoms without adequately understanding the problem. And that's really what I want you to take away from this video. Sleep medications can absolutely have a place in treatment. And I'm not anti-sleep medication. And I'm not going to tell you that everybody needs to meditate, put their phone down, and drink chamomile tea. Insomnia can be miserable. It can affect your mood, your concentration, your physical health, your relationships, your work, your overall functioning. It deserves to be taken seriously. But taking insomnia seriously also means doing more than asking, what can we prescribe to make this person sleep? When a patient tells me nothing works for my sleep, My next question shouldn't automatically be, what medication haven't we tried? It should be, what kind of insomnia are we actually treating? Treat the person, identify the mechanism, and when the medication is appropriate, use it as part of the treatment plan, not necessarily the entire treatment plan. If you found this video helpful, like the video and subscribe to my channel. It helps me more than you'll ever know. And I'd love to know what you'd like for me to cover next. Do you want a video that's specifically about Trazodone, Melatonin, Ambien, or would you like me to do an entire video explaining CBT-I and what it actually looks like? Put it in the comments. I'm Robin, and until next time, be kind to your mind.